Lovely. Hello, everybody, and thank you very much for joining us for another one of our Meet the Specialist sessions. These short sessions are being viewed quite a lot by people because they're a great way to get a quick snapshot of what that doctor is all about, particularly if you've never booked with that doctor before, or if you just want to revisit a little bit of what they're like. And that will help you with choosing to book with them. Today, we have the very lovely Dr. Jeff Bertucen, who is a consultant psychiatrist. Jeff has worked with MAG for many, many years and is one of our special favourites. He writes a delightful report, excellent report. So if you're of need, he is one of our many people that you can book. Jeff's specialty, he commenced actually in general practice and emergency medicine before moving to psychiatry, where he now specialises in a range of different areas, including mood disorders, addiction medicine, sexual dysfunction, military medicine, and historical abuse matters. So without further ado, I shall hand you over to have a listen to what Jeff is all about, and perhaps at the end we can ask a few short questions. Thank you so much.
Hi, thank you, Michelle. My name is Jeff Bertucen. I haven't gone into this, I must say, with any distinct preparation. This is basically extemporizing, but as Michelle has already outlined, I have been practicing as a consultant now for the last 15 years, but was a general practitioner way back when dinosaurs roamed the earth almost, and life was in black and white. Michelle, remember when we were young instead of color? That's what I tell my kids, right? Yeah. So my work has been, since 2009, divided principally into a clinical component and a forensic or medico-legal component. And the proportions of that has changed. In the beginning, back in 2008, 2009, I was working mostly in clinical medicine at St John of God Hospital, where I still practice, although the medico-legal side of things was the tail back in those days, although in the last 15 years, the tail has grown to become the dog, and the clinical work is now the tail. And as Michelle has outlined, I am a civil forensic psychiatrist. I'm a foundation member of the forensic section of the College of Psychiatry. And civil as opposed to criminal forensic, I do not do any justice health work, although my civil forensic work can certainly cross those boundaries in that we interview an increasing number of incarcerated patients, don't we, Michelle, as you know, who are in most cases involved in matters of historical abuse, both sexual and occasionally non-sexual. So in terms of my clinical specialties, they are, as Michelle mentioned, mood disorders. Post-traumatic stress disorder comes high up in the list in terms of my clinical interests. And naturally, a very high proportion of our interview subjects for medico-legal reports are suffering from post-traumatic stress disorder. I happen to believe personally that it is very important, in fact, it's vital, in order to maintain a certain acumen as a report writer. I think it's vital to maintain clinical medicine rather than simply be involved in writing reports, because having that clinical foot in that section, I believe, can certainly contribute greatly to one's skill and acumen as a diagnostician and as a history taker, and that can certainly flow over in terms of one's proficiency as a report writer. So in terms of the topics, the subjects of medical legal reports, as Michelle from MAG, Michelle sends me a great diversity of subject matter. Many of them are motor vehicle accidents. Of course, increasingly we're starting to see a prevalence of medical negligence matters, and of course, historical sexual abuse matters. And these were, in terms of historical abuse matters, these were relatively esoteric, weren't they? And quite specialized until quite recently. But with the, I suppose, the rise of reporting of these kinds of incidents in the wake of various royal commissions, the volume of this kind of work has expanded exponentially in the last couple of years. So there certainly is a great requirement to provide medico-legal psychiatric services to some of these people who, in many cases, have been quite damaged by their experiences. So did anyone at this stage, and I don't know who is in the audience, by the way, don't know who's listening to this, but we might come to that. Presumably you can see me, or I don't know if you're just listening, but I can't see anybody apart from Michelle. But if anyone has any specific questions above and beyond what I've just mentioned, I'm more than happy to answer them.
Terrific. Thank you for that little snapshot of you and what you do. If anyone would like to ask a question, please unmute yourself. If you don't know how to do that, just slide your cursor down to the bottom left of the Zoom screen and unclick the thing that looks like a microphone. Okay, I have 2 questions from people who were unable to attend today.
Okay.
So the first is, it's in relation to workers' compensation matters, and this is a white collar and office worker. And the question is, how do you discern the difference between an anxiety disorder and PTSD in a person claiming that they are so traumatized by workplace bullying that they can't go back to the office?
Well, this is a very interesting question, and it comes down to, I guess, the definition of the word trauma, inverted commas, in civilian usage, as opposed to the strict usage and definitions of trauma according to the DSM-5, which is the diagnostic statistical manual that we use as a benchmark for determining diagnoses. Now, people can be, inverted commas, traumatized by all manner of different occurrences. I don't put the inverted commas there to trivialize the word trauma, but trauma leading to post-traumatic stress disorder has a very distinct and definite set of criteria as laid down in the DSM-5. And criterion A in particular suggests, without necessarily getting it verbatim, but a trauma which implies a real or implied threat of serious injury to oneself or death. And the situation is experienced with horror or helplessness. Now, typically, we see these kinds of diagnoses in very severe motor vehicle accident cases in which, for example, for the sake of argument, a person is nearly killed, or a passenger of a vehicle is killed, or a motorist witnesses death, etc. In our emergency responders, such as police and ambulance, these people are being exposed almost on a daily basis to these kinds of horrific traumas, which meet criterion A for PTSD. The civilian setting that you mentioned, Michelle, in which somebody is very traumatized, that can certainly lead to sometimes very severe disabling symptoms of depression and anxiety, but it is not strictly definable as post-traumatic stress disorder. Even if at times the sufferer of that kind of bullying and harassment may have symptoms consistent with PTSD. Sorry, what was that?
Sorry, there was a little bit of feedback. I've just sorted that.
Right. So taking this situation of the severe workplace bullying, individuals can sometimes experience characteristic symptoms of the PTSD syndrome, including flashbacks, avoidance of the location of the office, let's say, vivid nightmares of being bullied or harassed and so forth. And these can be very severe and disabling. But from the definition perspective and from the statistical perspective, it is not always, unless, of course, the bullying involves, as I said, potential or actual physical harm or risk of death, it is not definable under DSM-5 criteria as chronic PTSD.
Right. Thank you. Look, the second question I have is actually from a lawyer, and it's one that I actually find myself having to answer quite a lot myself when speaking with clients, and that is your views as a psychiatrist on the value or the difference between a telehealth assessment and a face-to-face assessment. And I preface this by saying, of course, that the pandemic has changed all of our views on this.
Yes,
so
100%.
Prior to that, a lot of psychiatrists and other specialists were very reluctant to do telehealth assessments,
me included.
believing that they couldn't perhaps observe the nonverbals and the other things as effectively.
Yes.
And yet what we've been seeing is that, in fact, when a person doesn't have to catch a long train trip into the big smoke and find the building and get to level 5 and fill in a form and sit across the desk from a shrink, that they're actually far more relaxed and forthcoming and far less stressed. What would be your take on that?
Well, I think you've almost answered the question, Michelle, and I, like many colleagues, were very reluctant to embrace that sort of remote viewing type platform or format for interviews, for precisely the reasons that you outlined. Are we going to, for example, notice if someone is unkempt, if they haven't had a wash, if there's any features indicative of poor self-care, if there's any unusual twitches, blah, blah, blah. But as things progressed throughout the pandemic and we were obliged to keep interviewing patients in this way, I think for most of us, it became quite clear that not only were we able to discern these kinds of factors, but as you indicated, there are many positives to the telehealth assessment. If we can interview a client in their fluffy dressing gown, in their lounge room, with their slippers on, in which case they are likely to be far more relaxed and forthcoming and open and candid and give a full history. As you say, for many of our clients in the old days, it may have been their first time to Sydney or to a big city for many years, and in some cases forever. And these people were petrified. The overlay of anxiety at the prospect of having to, sit outside the headmaster's office, as it were, and come in for an interview was an enormous factor, which I believe at times really did compromise the kind of history. We would have feedback from the lawyers saying, oh, look, my client was so nervous, they forgot to mention A, B, and C when they were there with you, and these are really important points, but they were just so anxious, et cetera, et cetera, et cetera. Obviously, we still do get that, but it's far less frequent and less traumatizing for the subject of the interview, I believe. And not only that, the lawyers love it because we have a national reach with regards to video conferencing. We can do our first patient in Mildura, the second patient's in Taree, the third patient's in Cootamundra, et cetera, et cetera, et cetera. There's obviously not the need for travel funding, accommodation overnight in Sydney during the period of the interview, et cetera, et cetera. So it's a big win-win, I believe, for clinicians, patients, and referrers on the whole.
Lovely. Thank you so much. Does anyone else have a question that they would like to pose, Dr. Bertucen? No? Oh, we've got somebody here.
Sorry, yep. I've just got one. It's Mark Weiss here. I work for a reinsurer and we deal with a lot of life insurers with day-to-day claim referrals. I'm intrigued with the treatment aspect, and we're seeing a lot more TMS being as a treatment regime. Mm-hmm. I'm interested to get what your views are regarding TMS.
Oh, well, that's more of a clinical question, I guess, rather than a medico-legal question. But in terms of the outcomes, personally, I'm not a major advocate of TMS. It's something that I would recommend perhaps as a third line of treatment. I find that TMS often benefits clients who, for various reasons, are maybe philosophically opposed to taking drugs, as it were, or medications, have had adverse reactions to antidepressants in the past and are a little bit wary of using them. For very severe melancholic depression, of course, ECT is still the gold standard. But for, as I said, people who wish to take a different pathway or have had multiple trials of antidepressant medications without success, TMS can sometimes be very, very helpful. Mm. It's much less invasive, of course. There's no anesthetic involved. There's no significant side effects reported. There's no sort of seizure activity per se. There's a little twitch. It's time consuming. When somebody has a course of TMS, generally it's 30 treatments, which take place over a 3-week inpatient program, and funding, of course, has to be provided for that.
Yep.
But if it works, it can be used as an ongoing basis as maintenance once a week or twice a week for an indefinite period.
Mm-hmm.
So, but look, the literature suggests that TMS has certainly a much higher efficacy than placebo, but less high than certain pharmacotherapies, and certainly less than. So it has an established place in the repertoire of treatments, put it that way.
Okay, thank you.
Thanks,
Thank you
Mark.
so much. Well, look, everybody, we've got to wrap this up now, but thank you so much for joining us to listen to Dr. Jeff Bertucen, clinical forensic psychiatrist and great friend of MAG. I hope you all have a great rest of the day. The recording of this session will be sent out to you within a day, and it will, of course, always be up on our YouTube channel for you and your colleagues to view. Thank you so much, Dr. Bertucen, for your time today. Really appreciate it. Have a great weekend, everyone.
All the best. Bye-bye.